Okay, so we'll start off the seminar with a bit of information about the acid-base balance and the acid-base irregularities. So what you have to know, or what you're expected to know for your upcoming test, is whatever is on this slide. So you have to basically know about acid-base physiology. This you can learn from your second year physiology, and also like it's there on your scripta for the third year pathophysiology. And then you also have to know about the assessment of acid-base balance and how the parameters pH, partial pressure of carbon dioxide in arteries, and the plasma concentration of bicarbonates is used to determine. And you use the Henderson-Hasselbalch equation to determine the pH of blood using those parameters. And then I believe it's supposed to, you also have pKa in there, but you have the formula in your lecture slides anyway. And what's very important, not only for the pathophysiology test, your final exams, but also it's important for your life as clinicians, is the anion gap and the strong ion difference. I believe the anion gap is more commonly used, but the pathophysiology department expects you to know both anion gap and strong ionic difference. And so I will be covering a bit more detail on that and perhaps give you some tricks to help you understand it better and perhaps memorize it as well. And obviously, the anion gap and strong ionic difference, they're used for metabolic acidosis and alkalosis. They're not used for their respiratory counterparts. And then the other things you're expected to know is like acidosis and alkalosis, like their division into metabolic respiratory, some etiologies, signs, symptoms, and suggested treatment. And obviously the difference between acute and chronic respiratory acidosis alkalosis. The difference, to summarize for you, is that in acute, the compensation has not occurred, which is the renal compensation mostly, and chronic, the compensation has occurred. You can go on to the next slide, 13. All right, so there are lots of etiologies of acid-base disturbances, right? Especially the metabolic ones. But I think it personally boils down to these 5 main changes in parameters. And if you're able to remember these 5 and derive whatever is happening within the patient back to these 5 main etiologies or causes, then you will sort of always be able to deduce like whether the patient is going into metabolic acidosis or alkalosis if they are going into that stage. So, for example, there can be changes in acids, right? So, if in case of excess acids, so let's say the patient has, for some reason, consumed acid. So you can sort of assume that, okay, this would lead to a change in acid, so an increase in H plus, so must be acidosis. Well, obviously, consumption of acid is very direct, but let's say the patient goes into like aspirin intoxication, like they overdose on aspirin. The chemical formula for aspirin, or the chemical name of aspirin, is acetyl salicylic acid, and it's an acid after all. So there you go. There's an increase in the amount of acid in the patient's plasma, and therefore it will lead to acidosis. Similarly, the loss of acids would lead to alkalosis. And an example of like a situation where you'd have loss of acids commonly is vomiting, where you'd have loss of not only H plus but also chlorides. And then similarly, there are some other reasons here. So the changes in bicarbonates, changes in chloride, changes in phosphates, sodium, which is dilutional or concentrated, and then changes in albumin. Now, it is important to note that albumins, you cannot really have hyperalbuminemia, but rather you can only have hypoalbuminemia. And this would only arise in metabolic alkalosis. And the changes in parameters in which acidosis or alkalosis arises, it's mentioned in that slide. Okay, so first and foremost, I'd like to talk a bit more about anion gap. So what exactly is the anion gap? It is important to know that when a patient's blood or plasma is analyzed, you analyze both cations and anions, but the catch is you don't really analyze all the anions. You analyze the main ones, which is usually chlorides and bicarbonates, the two most abundant. So when you subtract the concentration of cations from the concentration of anions, you realize that there's a gap that's not accounted for. And that essentially is what the anion gap is. Now, the anion gap The corrected version consists of three main components, which is albumins, phosphates, and unmeasured anions. And this is what the pathophysiology department expects you to know. The principle of this is electron neutrality, and that basically, like, it's a fancy way of saying that the plasma has to be electroneutral, meaning that the charges, both positive and negative, have to cancel each other out. And yeah, the corrected AG, the important parameters, albumins, phosphates, and unmeasured anions, are mentioned here. And the anion gap, particularly changes in it, can help us determine the nature of like an acid-base disturbance, particularly the metabolic one. Next slide, please. So first and foremost, I'd like to talk a bit about metabolic acidosis with respect to the anion gap. So for changes in the anion gap with respect to metabolic acidosis, you can have either an increased anion gap or you can have a normal anion gap. And once again, it is those 5 or 6 basic reasons that I mentioned in the first slide. You basically plug it into this equation, or not into this equation, but rather this diagram of anion gaps, and you'll be golden in determining whether the patient is developing acidosis and alkalosis or whether it is with hyperchloremic, sorry, is it with increased anion gap, normal anion gap, etc. So to sort of explain it, it is a bit complicated, but let's say an increased anion gap. When can you expect an increased anion gap? What are the components of an anion gap? Albumin, phosphates, and unmeasured anions. Unmeasured anions, or UA for short, is most probably some sort of acids. So increased anion gap would be, for example, in case of increased H plus, so that would increase UA and therefore increase the anion gap. Or if there's hyperphosphatemia, in which there's increased Ag and therefore, well, there's the increased anion gap. And then there's also normal anion gap, and this can be further divided into non-dilutional and dilutional. So non-dilutional meaning like you don't dilute the blood necessarily. And this can be, for example, in hyperchloremic. And the reason why hyperchloremic would lead to normal anion gap is because even though hyperchloremia is supposed to push down on the anion gap, therefore making it smaller, there's also basically relative changes in the concentration of bicarbonates. Similarly, if there's loss of bicarbonates, there would be increase in chlorides and sort of increase in the constituents of the anion gap. So the anion gap remains relatively normal. And then you have dilutional or hyponatremic, which basically means that you dilute the blood. It's a very weird term, but you dilute the blood with physiologic solution, which is 0.9% sodium chloride or saline, basically. And the reason why this dilutes blood is because the saline has a sodium chloride ratio of 1 to 1, but that is not the actual ratio within the human plasma. And therefore, when you add excess amounts of sodium, like sodium chloride in a 1 to 1 ratio, it not only increases the amount of chlorides, so in a way you can assume that there might be some sort of hyperchloremia, but in reality there's not. You're adding mostly water because it's just 0.9% sodium chloride, right? So it sort of dilutes the, how do I say this, the parameters in plasma altogether. And therefore it reduces not only the anion, not it reduces not only the components of the anion gap, but just all the anions in general. And concentration is a relative parameter. So a concentration of certain ion would be relative to some other. Let's say if um, the plasma were to have only two parameters, chloride and bicarbonates. If chloride goes down, that means bicarbonate must go up. So in this case, since all anions are going down, in case of dilutional or even concentrated, which is in metabolic alkalosis, the anion gap remains normal. That was a bit complex, but I really hope you understood like why exactly dilutional concentration does not really cause any changes in the anion gap. So you can go to the next slide. And now the same thing with metabolic alkalosis, and you sort of just reverse the etiologies, except you also add for decreased anion gap the albuminemia. And as mentioned before, you cannot have hyperalbuminemia because the body doesn't really generate excess, how do I say this, plasma proteins, but rather the body can lose excess plasma proteins. And this can be, for example, not only loss, but also in case of decreased synthesis. So, for example, any sort of liver disorders such as liver failure, liver cirrhosis, or it can also occur and if there's excess loss of albumins, and this can be, for example, in nephrotic syndrome. And for normal anion gap, it's the same parameters, but you just reverse the reasons. So maybe in metabolic acidosis, you'd have normal anion gap with hyperchloremic etiologies, whereas here it would be hypochloremic etiologies. Similarly, the previous one, it was dilutional acidosis. In this case, it would be concentration alkalosis. And once again, the reasonings are just flipped, just make everything an opposite. You can go to the next slide. And there's the second thing, which is strong ion difference, or SID. I'll be referring to that. I'll be referring this as SID from now on. So SID, it has some complex way of being derived, but the main takeaway is that the parameters in SID are bicarbonates, albumins, and phosphates. And if you realize and you compare SID to the anion gap, you realize that there's a difference in parameters. Particularly, there's bicarbonates rather than UA. In this case, you don't really account for UA in the parameter called SID. So there would be different changes in SID with respect to metabolic acidosis and alkalosis. Next slide. Okay, so in acidosis, with respect to SID, you would have either decreased SID or you would have normal SID. And you can sort of predict the etiologies. So, for example, if there's decreased SID, then what are the parameters of SID? Bicarbonates, albumins, phosphates. So, for decreased SID, you can either have an increased amount of UA, which would decrease like the total, just decrease the parameter of SID, or loss of bicarbonates, or if there's, how do I say this, hyponatremia or hyperchloremia. And the reason why hyperchloremia would lead to decreased SID is, like, again, it's if chloride increases, other things must decrease, and therefore SID decreases. And hyponatremia, once again, is dilutional. One thing increases, the other, like, everything else decreases. And in case of normal SID, you would have hyperphosphatemia. Next slide. Again, the etiologies, you can sort of just reverse it as it was for acidosis. So for increased SID, you'd have whatever, and for normal SID, you'd have the changes that are mentioned on the slide. So it is a lot to remember, but as long as you sort of remember these 5 or 6 basic etiologies and where exactly they fit in to the anion gap or SID, you should be able to estimate, like, whether the patient is undergoing acidosis or alkalosis, and whether this acidosis is with increase or decrease anion gap or SID, and whether if it's hyperchloremic or hypochloremic, etc. Next slide. So there's some tips that I use to memorize exactly, or not really memorize, but rather orientate myself, right? And that is, there's always a normal for anion gap and SID, and there's either an increase or a decrease, right? And it is always opposite in each case. What I mean by that is, for example, for metabolic acidosis, I remember that both AG and SID, there's normal, right, for both, once again. Now, how do I prevent getting confused on in which there's increase and which there's decrease? Well, that's easy. I just remember for anion gap in metabolic acidosis, there's always an increase. So if there's always an increase for anion gap in metabolic acidosis, that means for SID in metabolic acidosis, there would be a decrease. And that also helps me predict, or basically determine, what would be the case for metabolic alkalosis. So if I know that in metabolic acidosis, AG would be increase in normal, for metabolic alkalosis, it would be like AG would either be decrease or normal. And similarly, the opposites for SID in metabolic alkalosis, the SID would either be increase or normal. It's a bit confusing, I know, but this is what helped me memorize, and I just thought I'd put it out here in case it helped you guys as well. And that is all the explanation I have for metabolic acidosis and alkalosis. It is a bit complicated, I understand, but the earlier you grasp this concept of anion gap and SIB, the better it is for you to like orientate yourself. So now if you guys could just join the Slido, whatever, there's a QR code and there's also a number that's provided on the screen. And there's some questions I have for you regarding the acidosis and alkalosis lesson. It's just to sort of brush your memory on acidosis and alkalosis and also to test the concepts that were just taught. How long are we giving them to join exactly?
You guys can start joining. Let's give them 2 minutes. Try to join using the QR code. If you can, join slido.com, and I think it will give you like write this number, and we'll start in 2 minutes. So I think we will start. Do join the quiz. You don't have to write your name. You can go by. Yeah, exactly. Thank you. Anything works.
Oh,
You can be
it's just
anonymous.
one person right now.
Huh?
Is it just one person right now that's in the
Um,
quiz? Okay, no,
I
there's two now.
Guys, don't miss out on the opportunity to test yourself. It's like the best way to figure out your shortcomings. Like, it's like the top method of learning anything. And it's better to find out where you're lacking now than find it out on Wednesday during the test. So, no one's going to judge you. You don't have to use your real names. Just do this to find out where you're lacking.
exactly.
Precisely.
Thank
And
you.
I think personally that you learn better and it consolidates your memory way better if you make a mistake rather than just learning it for the first time. And if you guys do have any like confusions with the answers that are correct, please do leave them in the chat or like feel free to unmute and ask because I am more than willing to explain.
So I think we can start so we don't waste anyone's time. Love the names. Um, but yeah, let us start. And guys, it had a timer, so it's 45 seconds. This is just to simulate the real life conditions of the exam because usually in the exam you'll have like I'm not sure how many, usually 30 questions. 30, yeah, 33 questions or something like that, and they'll give you 13 minutes. And you think it's bad, but it's not. It's just you need to manage your time and know how to connect the dots quickly. And I think this test is like a practice for you guys. So again, good opportunity. So we can start.
That's pretty nice, actually. Do I need to explain any of the reasons? But because I think most of the people got it.
Does anyone have any questions about this one? Is anything not clear? Do you need explaining? Just let us know.
I think I will explain the ethanol one because I think the liver failure and increased AG is just pretty direct. So the thing about the ethanol one, it is kind of indirect and it requires you to think. And the reason why ethanol or increased ethanol consumption would lead to lactic acidosis is because in case of increased ethanol, there would be greater metabolism of this ethanol, and that would result in greater production of reduced NADH. And this reduced NADH would sort of increase the pyruvate metabolism to lactate. So essentially what's happening is that there's increased lactic acid production, and if there's greater lactic acid, that means lactic acidosis.
So if this is clear, we can move on to the next question. So we can check the answers. Like, yeah, don't stress out. I can see the number increasing. Okay. So
That's pretty nice, actually. Yes, respiratory alkalosis can lead to tetanic cramps because it reduces the amount of H plus in the plasma, and that would basically increase the amount of calcium binding to the albumins, which they compete with H plus for, and this would reduce the amount of ionized calcium. So that increases the excitability of neuromuscular junctions and therefore leads to tetanic cramps. The other thing, I think everyone answered correctly. Arise in high mountains panic disorder. Both of them are associated with hyperventilation. Hypokalemia, yes, it can lead to that. And the reason is because, once again, the amount of H plus is lower in plasma. And because there's lower H plus, there's a cellular compensation in which there would be efflux of H plus into plasma and influx of K plus into cells. and that would basically lead to hypokalemia. Like it has a hypokalemic tendency. Hmm. Okay. That's weird. Uh, okay, so it does increase in hemolysis. And
So for kalemia, yeah, this is right. The reason why there is an increase in kalemia and hemolysis is because you should know that intracellularly, the kalemia levels are much higher than extracellularly. So when the RBCs burst, they're releasing all of this K plus. So as for alkalosis, as totally explained, the antiport mechanism between like H plus and K plus, you would have an increase in alkalosis. For insulinemia or insulinism, basically hyperinsulinism or insulin causes an influx of K plus into the cells. So in fact, it will cause hypokalemia, not hyper, because most of the K plus will be going into the cells when there's insulin. As for the last one, it's not stop of heart and systole, it's stop of heart and diastole. So it's just simple, straightforward facts.
So if this is clear, we can move on to the next question. Okay, the last 10 seconds. Okay, we can check the answers.
okay, so majority got hypokalemia and alkalosis, but yes, it is a bit confusing why it would lead to decrease in pH of urine. It is again a long shot, but the reasoning is that when a person vomits, it would lead to, how do I say this? Like, okay. Yeah, sorry. It would lead to, what was the thing again? Right. It would lead to metabolic alkalosis, right? So I think it leads to metabolic alkalosis. And what that would do is it would try to retain the amount of. Okay, no, I think this is wrong actually. The
Okay,
decrease in pH
so
of
for
urine.
the decrease the pH of urine,
Yeah, I think this is wrong. This is not
no,
supposed to be correct.
it is correct. It is because when there's vomiting, there is loss of fluid.
Hmm.
So this is hypovolemia, and with the compensation method for hypovolemia is by the release of aldosterone. So aldosterone
All right,
works
yeah.
on the kidney by eliminating, by reabsorbing sodium and water follows and excreting potassium and H plus, and that's why the pH of the urine decreases.
See, I have a question. The reason why I doubted this is because the renal compensation for like an alkalosis would be to retain the acids, no? And if there is like a compensation to retain the acids, that would increase the
E-
pH of urine, not decrease it.
yes, but we have priorities in terms
Hmm.
of like
Yeah, yeah, yeah,
volume,
yeah,
osmolarity, and acid base balance. Yeah.
yeah. Yeah, okay.
So right now, the body doesn't care about is it acidic or alkalosis. It cares about the volume that is being lost. So that's why the pH of the urine will decrease.
Okay, yeah, perfect.
Yeah, just to remind everyone, the priority for the body is volume, osmolarity, and then pH.
Okay, I think we can go to the next question.
Okay. 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 So the answers.
Yep, precisely. I mean, diarrhea would not lead to hyperchloremic. Oh no, sorry, it would lead to hyperchloremic, yeah, physiologic infusions. It wouldn't lead, it would lead to hyperchloremic as well. Um, Both of these are not normal anion gap, and Fanconi syndrome would do the same. And the reason why Fanconi syndrome would lead to normal anion gap hyperchloremic metabolic acidosis is because it decreases the bicarbonate retention. So when there's decreased bicarbonates, you would have an indirect or relative increase in the chlorides, and therefore you would have hyperchloremia. And the reason why diarrhea does it is it's again like the same reasons. In diarrhea, you're losing more bicarbonates, so you would have a relative increase in chlorides, and therefore you would have hyperchloremic metabolic acidosis.
Is this clear for everyone? If you guys have questions, don't be shy. You can like turn on your mic. You can type it in the chat. It's okay. Like this is a safe space. No, I'm so sorry. Okay, we will go on to the next question.
Yeah, I think that is it for me, no? Like I'm not doing any more questions.
Yes, you're done now. Nilaya's turn.
All right, I shall pass the mic to Nilaya.
Okay, thank you.
I caught it.
Okay, so the
Okay.
answer.
So I see that all of you got it right. So that's great. So obviously the first one's wrong because this happens because of retention of urea and it doesn't have much to do with ammonia. The second one's also wrong because it manifests either during or after dialysis, not before. Because what's happening in disequilibrium syndrome is that because urea is not like it doesn't pass very quickly across the blood-brain barrier, it ends up getting retained within the brain, while the rest of the plasma is like rid of this urea. So as a result, the brain becomes sort of the brain tissue becomes more hyperosmolar. It ends up pulling water and it results in cerebral edema. It's easy to understand, I believe. And it is definitely an emergency because cerebral edema can be life-threatening. It could lead to like tonsillar herniation. It could affect the respiratory centers. So you should treat the patient quickly or else they'll die. I think we can go to the next question. Okay, so it looks like you guys did see the plus, but this was an easy question too. So it definitely can manifest in someone with a head injury because a head injury, there's two syndromes here to keep in mind. Cerebral salt wasting syndrome and syndrome of inappropriate release of ADH. It's very wordy, SIADH. So what happens in CSWS and SIADH, they're sort of similar, but not the same. So I'll just talk about it a bit. What is happening in CSWS is because of the head injury, you end up secreting a lot of ANP, CNP, BNP. And what this does, it's going to inhibit RAS. And as a consequence of that, you're going to lose your solutes because you know that aldosterone was responsible for the reabsorption of sodium and stuff like that. So when you lose stuff like sodium, you end up losing the medullary osmolarity balance that you had, if you remember from physio, like how the concentration kept on increasing as you were going towards the loop of Henle. And this was all to allow you basically to reabsorb water. So because of the loss of solutes now, you're not able to. Yeah, I was still talking about it. Is it not clear? Uh, okay, I can start from the beginning again. Okay, so CSWS, you have head injury. Because of that, you are secreting inappropriately stuff like the natriuretic peptide. So BNP, ANP, CNP, you're going to start secreting this when you shouldn't be. Because of that, you have an inhibition of RAS. So what would RAS normally do? RAS would normally help reabsorb sodium, reabsorb water, and maintain like an isoosmolar fluid sort of because you're absorbing sodium and water. But now, because of the inhibition of RAS, you're losing the sodium and you're losing the water. And because of this, you cannot, like, you're losing the medullary osmolarity balance as well. So even if ADH tries to compensate in this situation, you aren't able to absorb water as effectively because of all of the solutes you've lost. So the consequence of CSWS is that you develop hypoosmolar because of the loss of sodium, as well as hypovolemia, because like I explained, you're not able to absorb the water effectively because you've lost the medullary osmotic balance. Now, coming to SIADH, here the issue is not with ANP or BNP or whatever. Here, the problem is it's an inappropriate release of ADH. So because of that, what does ADH do? It's anti-diuretic hormone. So you're retaining water, and it's very obvious over here that it would lead to hypoosmolarity because you're like diluting the blood effectively. And because of that, you get hypoosmolar hypervolemia. So that is the difference between SIADH and CSWS. I hope it was clear. And then coming to the third option, it's obvious it's not salt water because it says hypoosmolarity. In fact, this would happen if you drank pure water after sweating. But it might be a bit confusing how it arises because sweat is considered a hypoosmolar fluid. So if you were to lose a hypoosmolar fluid, initially you would have hyperosmolarity. However, because of this intake of pure water, this changes and it turns into hypoosmolarity. I hope it was all clear. Does anyone have any questions? I think if not, then we can go to the next question. Okay, so I see a few of you picked the first one. So you might while you're thinking quick, you might end up doing it, but remember that like in Scripta as well as the PPT, they've mentioned that it could be because of retention of any other osmotically active substances as well. And they've given an example of hyperglycemia in uncontrolled TM. So do keep that in mind, like minor details, because they tend to ask about that. I see most of you picked the second option, which is correct. And how this happens is Cushing's ends up causing hypercorticolism. As a consequence of that, you end up retaining isoosmotic fluid. But whenever you're like retaining isoosmotic fluid, there's also something to consider that pressure diuresis occurs. And after that, when you end up losing more water compared to the amount of solutes, then you end up in a situation of hyperosmolarity. So but most of you got it right. So I believe you already know it. Then could be a result of watery diarrhea. All of you picked it, which is good because watery diarrhea is a hypoosmolar fluid. So whenever you're losing a hypoosmolar fluid, it is understandable to develop hyperosmolarity. And none of you picked swelling, which is great because exeposis should occur, not swelling.
So we can move on to the answers.
Okay, so I see that all of you picked the conus occipitalis one, which is true. I don't think that requires explanation. The next one might be a bit tricky. This one was actually no, but you all got it right. Okay. So what it says in scripta is that what happens in menstruating women is because of estrogen, the adaptation mechanisms end up getting blocked. So they may be lost in menstruating women, not menopausal women who actually would have like lower estrogen levels compared to someone who is menstruating. Um, we must treat chronic hyponatremia immediately. No, because you will end up killing the patient because their adaptation mechanisms will be interfered with, and that can be lethal for them. And it's, yeah, and none of you picked that one as well. That's great. That one's supposed to be astrocyte exocosis predominantly. And I think we're done with my topic, and now we're going to be moving on to tertiles.
Okay, so I'll do the first question, then we can move on to the PPT and I'll discuss a bit with you guys about hyper and hypovolemia. So we can start with the first question for now. So we can check the answers. And okay, so hypervolemia can be associated with bronchogenic carcinoma. Does anyone know how and why? Like,
Yes, I know it.
thank you, Tawhid. But like, any of the third years know why?
Because it secretes ADH.
Exactly, exactly. Like, so it's like it can cause syndrome of inappropriate ADH release, and that's why it causes hypervolemia. So again, syndrome of inappropriate ADH release, or also could be syndrome of increased ADH release. It causes increase in ADH, so more water will be reabsorbed, and in the circulation there's higher volume of water, and that's it. SIDH is associated with hyponatremic hypervolemia. It's just because ADH, the aquaporins that ADH like places in the membrane, they only reabsorb water and no other mineral. So it's only logical that it causes hyponatremia. And increased thrombogenesis. Um, Not really. Increased thrombogenesis usually occurs with like hypovolemia because there's then usually increased viscosity of the blood, and it's one of the conditions that for thrombus formation. I don't think you took it yet, but when you take it, like one of them is like increase like stasis or turbulence of the blood, which in hypovolemia causes thrombogenesis. And hypervolemia, because of the overload, can cause heart failure. It can worsen the circulation. The heart is overloaded and causes heart failure. If we go to the presentation, sorry. Okay. Here, I mean, you guys know hypo and hypervolemia and the mechanisms. Hypovolemia usually is compensated by ADH and the RAS system, and hypervolemia, there's like pressure diuresis, decreased ADH, and the natriuretic peptides. If we go to hypervolemia according to the etiology, please remember this table. This table will save your life. I think if you know it like by heart, it will save you so much time during the test. And I know there isn't much time during the test, so like put in the effort to memorize it. Of course, understand it, but like memorize it as well. I wanted to ask, uh, does anyone? Okay, Nilay explained this, but can anyone re-explain why hyperaldosteronism and hypercorticolism causes hyperosmolar hypervolemia? You can turn on your mic. Why is it not isoosmotic hypervolemia?
I can explain.
Okay, do tell me.
So hyperaldosteronism and hypercortisolism, they basically do the same thing where they allow isoosmotic fluid to be resorbed in the kidney.
Mm-hmm.
And when we retain a lot of that, then we have pressure diuresis, where we lose more water than sodium. So we have hyperosmolar hypervolemia.
Excellent. Amazing. See, this is, if you guys remember, like, think about it logically, it will be so easy. So amazing. This is great. And I think now we can go back to the questions. You guys studied well. That's good. That's good. Okay, I think this is also good. So hypovolemia can lead to kidney failure. I think this is because of hyperperfusion of the kidney. The kidney is not receiving enough uh, blood. It logically leads to kidney failure. Uh, just remember, you need to drink water to maintain the kidney function, and so hypovolemia is bad for the kidneys. So this is an easy way to remember it. But if you want the explanation, it's because of hyperperfusion of the kidney. And sweating leads to hyperosmolar hypovolemia is because the sweat is a hypoosmolar fluid. So you're losing basically more water than actual solutes. So the solutes are in the blood, so it's hyperosmolar hypovolemia. And if we go back to the presentation again, it's the table. It's from the presentation. I think again, just remember it. It's really good. Um, we can we can like if someone can tell me about like vomiting, like why is vomiting hypoosmolar? Again, you can turn on your mic or you can type it in the chat. Does anyone remember?
I can answer again.
Okay, go ahead.
So when you vomit, you lose ISO, a smaller fluid,
Mm-hmm.
and then that's compensated by RAS, and then again, ADH absorbs water, so hyposmolar is the result.
Exactly. Thank you so much. Excellent answer. I think for a lot of the yeah, Tawhidul, go ahead.
No, I meant to clap. I'm sorry.
Okay. And for a lot of the hypoosmolar hypovolemia, a lot of it is caused by the later compensation by aldosterone and ADH, which absorbs, especially ADH, which absorbs more like simply water. So it dilutes it. So that's why a lot of it is hypoosmolar. For hyperosmolar, it just makes sense. Like you're losing more water than solutes in very watery diarrhea because it's hypoosmolar. There isn't um uh diarrhea alone is hypoosmolar, but it's compensated. But very watery diarrhea is like a huge volume of hypoosmolar fluid. And sweating, we discussed it. Sweat itself is a hyposmolar fluid, and polyuria is basically it means that the kidney has lost its ability to concentrate the urine, and so more like a hypoosmolar fluid is lost. So, yeah, I think we can go on to the next question. If you guys have any question, please at any time stop me, or type it in the chat, open your mic. It's okay. Like you can ask the questions now. I'd rather you guys ask the question now.
How many minutes is the exam?
It depends. Usually 11 to 13 minutes, if I'm not wrong. Yeah, 11 to 13 minutes. We'll tell you guys more about how to approach the exam by the end of this seminar. We'll finish the questions and then we'll just give you guys some general advices and for the test. So we can go on to the next question. so we can discuss it. Hopefully everyone, okay. Okay, so I'm glad none of you chose the first option. Which osmotic diuretic does not non-osmotic diuretic does not cause hypoosmolar hypovolemia?
Loop diuretic.
Yeah, exactly. Potassium sparing diuretics are compensated by ADH only. I mean, if the potassium, do you know the mechanism of potassium sparing diuretics is either it's antagonist of aldosterone or it inhibits the epithelial sodium channels. So it blocks the action mainly of aldosterone. So it just makes sense that it cannot be compensated by aldosterone. It's only compensated by ADH. That's really the explanation. Yeah. For thiazide diuretics, can lead to hyperkalemia is wrong. Do you guys know why? Why does it not lead to hyperkalemia?
Because it's compensated by aldosterone. So
Exactly.
it releases hyper. Yeah, you get it.
Yeah, exactly. Thank you. Because thiazide diuretics are compensated by aldosterone, which causes hypokalemia. Exactly, hypokalemia. And spironolactone, which is a potassium-sparing diuretic, it inhibits the ENaC channels or the amyloidoid. Yeah, I think that's how you pronounce them, channels. But no, spironolactone is an aldosterone antagonist. There are other like potassium-sparing diuretics that directly inhibit the channels, but spironolactone is an aldosterone antagonist itself. Um, yeah, I think that's it. Do you guys have any questions for this one, or can we move on? If no questions, we can move on. Yes. Okay. We can discuss the question. Okay. So it can also, I think in the lecture it's written it can lead to later hypoosmolar, but you can define bleeding both as iso and hypoosmolar hypovolemia. But for now, I wrote isosmolar hypovolemia, and it is correct because blood is isosmolar, and you're losing blood, so isosmolar hypovolemia. Addison's disease leads to hypoosmolar hypovolemia is correct because Addison's disease basically is adrenal insufficiency. So you don't have enough aldosterone and uh, corticosteroids as well, like all of the adrenal hormones. And if you don't have enough aldosterone, you don't have absorption of like sodium and water. So both sodium and water are lost. And you have the state of hypovolemia. At first, it's isosmolar hypovolemia, but eventually, because of the compensation by ADH, there is hypoosmolar hypovolemia. Pyelonephritis can lead to hyperosmolar hypovolemia. Okay, this is maybe difficult. Pyelonephritis is it's a kidney disease that causes polyuria, and I think it's written in scripta like kidney diseases with polyuria like pyelonephritis and glomerulonephritis. So pyelonephritis is a kidney disease that causes polyuria and hypoosmolar fluid is lost, so you remain with hyperosmolarity and hypovolemia. And diarrhea is associated with metabolic acidosis with hypoosmolar hypovolemia is correct. Diarrhea basically is uh, increased intestinal flow. So you're losing bicarbonate. So this is metabolic acidosis, which is defined as decreased bicarbonate. And you also lose isosmolar fluid. And again, by the compensation of RAS and ADH, it leads to hypoosmolar hypovolemia. Is this clear? Do you guys have any questions about this part? Any question about hypervolemia or hypovolemia in general? If not, then we can move on to the last set of questions with Fatima.
Yep.
Okay, so I think we can discuss the question. Yes, thank you.
Okay, that's really good. Majority of you know what's happening here. So it's true, it's in both hypo and hyperthyroidism. If you remember the classical image or clinical features for both of these cases, for hypothyroidism, it's a very classical picture of a lady with a very puffy face. So that's a facial myxedema. Versus in hyperthyroidism, it typically presents as like a pretibial myxedema. It looks quite hard and everything. So these are both two different types of myxedemas, and they do present in both hypo and hyper. Um, and the second point is true. This is especially for hypothyroidism. Typically, pitting edema, that is not the case. And this is because, let's take the pretibial myxedema in hyperthyroidism as an example. So the mechanism that's happening over here is that basically there is a proliferation of fibroblasts, and that is what causes the non-pitting edema to happen in pretibial myxedemas versus in hypothyroidism, the facial myxedemas. You would know that there's an increased mucopolysaccharides, and yeah, it does drag in water, it retains water, but the fact is that this is still a protein in the end, and obviously because of higher protein content, it would end up being a non-pitting edema. So myxedemas are generally non-pitting. As for part of premenstrual syndrome, more commonly known as PMS, mixed edema is not part of PMS, but instead edema of, for example, the breast is, and that is because of hyperemia that comes from changes in the female hormones. But mixed edema is not related to premenstrual syndrome. If this is clear, I think we can go to the next question.
Okay, so we can check the answer.
Okay, so yes, that's correct. Anasakara is a severe form of pitting edemas. Does anyone remember an etiology for this generalized edema? Like, what could be a cause for such a entire body severe form of pitting edemas?
Is it just hypervolemia?
It could be, yeah. It could also be because of issues like heart failure, very severe forms. So, but yeah, that's correct. Thank you. The second point, due to high protein and low water content, that's not true. This high protein and low water is for non-pitting edemas. The reason why pitting edemas are called pitting is because when you press onto them, it forms a little pit that stays for a while, even after you remove your finger. And the reason why is because the water that is initially present in that area, it moves away when you push into that area, and it takes time for the water to come back into the area that the pit was in. So generally, pitting edemas have a higher water content and a lower protein content. If it has a high protein but low water, that's a non-pitting edema. Occurs in renal failure. Yes, this is true. So generally in renal failure, you have a reduced glomerular filtration rate. So usually edemas would also come with like hypertension, and it's not exactly known the exact cause of the special type of edema seen in renal failure, but you can assume that perhaps the hypertension or the reduced GFR is what contributes to an increased hydrostatic pressure. And you know that one of those factors results in edema formation. Does anyone remember the specific form of edema that is seen in renal failure?
Periorbital?
Yes, that's correct. So it's not sure why exactly it's periorbital and not like generalized or anything else, but yeah, just wanted to state that. As for lymphedema, that's not the case. Lymphedema is a non-pitting edema, and I think that is because lymph also contains like some proteins, so it would be non-pitting.
Can you explain what Anasakra is?
Yeah, so anasakra is simply generalized or severe form of edemas, and it can occur in case of heart failure. So, you know, the main factors for edemas to occur is one of them is, for example, the hydrostatic pressure, a very high hydrostatic pressure. And the reason why I mentioned heart failure is because usually in heart failure you have congestion everywhere in the vessel, so you have an increased hydrostatic pressure, and that's why the entire body ends up developing these edemas, and usually it starts in the lower limbs, but anasakra refers to generalized edemas.
Okay, thank you.
Any other questions? Okay, it's fine, we can move on.
Okay, so now we can check the answers.
Okay, so this is good. The reason why it's not right heart failure is, well, first of all, it's because of left heart failure. When you think about the entire pulmonary circulation, so you have blood from the right heart that goes by the pulmonary arteries to the capillary system in the lungs, and then by the pulmonary veins, and then to the left heart. So right before the capillaries from the pulmonary arteries, there is a protective mechanism, which is the precapillary sphincters, which basically you learn more about this in respiratory, but it's a protective mechanism that prevents edemas from forming. So any right heart issues will not result in pulmonary edemas, and instead the left heart issues, the post-capillary sphincters are not present. So basically there is no protective mechanism from like causes of left heart failure to result in pulmonary edema. So in fact, left heart failure will result in pulmonary edema because there are no protective mechanisms. So anything else that can cause left heart failure, for example, mitral regurgitation or mitral stenosis, can also result in pulmonary edema. You can also think that mitral regurgitation could be because, well, there is backflow of blood and then that will go into the pulmonary system and then that will cause the edema. Circulatory shock is true because when you learn more about shock, but during shock you have acidosis and you also have reperfusion injury. But essentially what happens is that the acidosis, which you're already familiar with, can increase the permeability of vessels, and you know that is one of the factors to form edemas. So that's true. And severe alkalosis, that is not the case. It is the case for acidosis because acidosis causes increased permeability, not alkalosis, and that's how you get edemas. And if you're wondering why exactly like acidosis results in edemas or increased permeability, it just happens to be one of the changes that occurs on a cellular level in the presence of acidosis. So the gaps between the endothelial cells just increase and permeability increases, and then you have edemas.
So you're telling that severe acidosis would cause edemas?
Generally, acidosis will cause increased permeability of vessels, so that's why you'll have edemas. Does that make sense?
Okay, thank you.
No problem.
Okay, we can see the answer. Okay, yes, we can.
Okay, so good responses again. I'm glad nobody picked the first one. Just a quick recap is that, yeah, it does affect on the severity because you know that moderate hyperkalemia will cause increase in smooth muscle excitability, but severe will cause decreased excitability because it inactivates the sodium channels, which is needed for depolarization. So first one's not true. Then results in hypoglycemia. Yes, this is because increased kalemia or hyperkalemia can cause increased secretion of insulin. And insulin is what results in increased uptake of glucose by the cells, aka hypoglycemia. As for chemotherapy, this is the same concept as the hemolysis. So chemotherapy is targeted against tumor cells. It causes what is known as tumor lysis syndrome, but generally it causes the rupture of tumor cells, and because of that, the intracellular K plus is released out into the extracellular fluid. So you have hyperkalemia. Is treated by glucagon? No, that's not the case. It's treated by insulin. Insulin is what causes the K plus to go into the cells to treat hyperkalemia. And otherwise, that is it. It's as simple as that. Are there any other questions regarding this question or kalemia and edemas generally? Okay, I think we're good then. We should be done.
Okay, so we can check the answers.
Okay, I think everyone has the hand of like kalemia and acidosis alkalosis, so I'll be skipping the first one. Second one, it's cardiac arrest in diastole, not systole. Then it can cause paralytic ileus. Yes, that's correct, because there's hyperpolarization of the smooth muscle cells in hypokalemia, and then the smooth muscles will not be able to contract. So that's why you have paralytic ileus. Can result from diarrhea. Yes, that is true. In the diarrhea fluid, what you lose is K plus, and you also have hypovolemia. So you have aldosterone, and then the aldosterone is going to cause further loss of K plus. It's true that you lose HCO3 minus during diarrhea, and it will result in metabolic acidosis, which will, on a cellular level, cause an increase in K plus in plasma. Um, but the net effect is still hypokalemia because again the body is going to try and compensate for the volume more than the pH. So the aldosterone effect will outweigh the balancing effect by the acidosis. So the net effect is hypokalemia and diarrhea. As for the last one, results in diabetes insipidus. So hypokalemia causes a condition known as calliopetic nephropathy. This is also known as the peripheral diabetes insipidus. So that's it. Any questions?
If that is all, and you guys have no questions, uh, also one last thing, it causes cardiac arrest in systole as long as it's in diastole, but that's hyperkalemia.
Yes, thank you for pointing that out.
It's okay. And um, okay, for general remarks on how to approach the pathophysiology, oh, sorry. Okay, so yeah, okay, congratulations, M, and then M, and then A. Amazing. Okay, for general remarks on how to approach the pathophysiology test, don't panic. You know, like be calm before the test. I think managing your time is the biggest problem. Usually people have like the time. So I think like, you know, uh, be aware of the time, but don't be too stressed about it. You have enough time to answer all the questions, so don't worry. And usually the questions are like this, you know, there's like one main heading and then there's uh, like statements under it. One thing you need to know is that sometimes all of them would be correct or all of them would be wrong. So it doesn't have to be like, there has to be like a correct answer. It doesn't have to be sometimes. Sometimes they're all wrong. So that's like one thing. Um, Also, don't forget to when you when you you know in the test usually you have to write like plus or minus if like the answer is correct. So if the answer is correct, you write a plus. If the answer is wrong, you write a minus. And be sure to write the plus and minus at the beginning of the statement, not at the end. I don't know why they hate that, but they hate that. So make sure you write it at the beginning. And one thing about the pathophysiology, yeah, go ahead, Fatima.
I just wanted to add a little bit of advice for the actual test.
Mm-hmm.
So because there's like a time constraint and there's a lot of reading to do, it can be easy to misread statements. So what I did that personally helped and I would recommend doing is to underline keywords in the sentences as you go through it. So I don't mean like, oh, make it look fancy or pretty or anything like that. It's just so that you can refer to the keywords quickly and think quickly and you don't mix things up and you're actually reading things correctly. So it can help prevent errors as you do the test.
There's one thing I'd
Also,
like to. Sorry,
you,
sorry.
I hope you're all aware of the fact that if you marked a statement incorrectly, you lose.
Okay, yeah. It's basically as I think as Tartil was about to say that unlike with other tests, wait, what? Is it on hold? Can you guys hear me? Okay. It was as Tarsil was about to say, unlike with other tests where if you didn't know the answer, you'd either select it or just leave it. Like in this case, you lose more than you gain by marking an answer that you're unsure of. So if you're unsure of an option, it would be best to just leave it blank and lose that like -1 as opposed to like gambling and possibly losing -2. Because sometimes that like that 1 point sort of decides whether you pass or fail the test. Although we are very hopeful that everyone will pass it.
And I think these are the advices. Also for acidosis and alkalosis, I suggest you guys draw the Professor Cooper will always tell you to draw the table thingy, so it's easier for you to understand what is happening, and easier for you to see like, okay, hypochloremia, okay, this happens, this. So yeah, and Nilaya, you wanted to say something?
Yeah, I just wanted to add that if you feel like you want to get used to the time stuff, we have like given you access to, I think, a few papers on the drive or something. So edit them in such a way that it like resembles the real test. Set a timer for 13 minutes and attempt it like as if you were in the real situation. And I feel like that really helps like how you would do it for sport for an ad. So like at least for your first try, it would help you be in that headspace, and then you can just use that in the actual situation, so you wouldn't be surprised or taken like you would be prepared for it. So if you have the time for it, I suggest you try it.
Okay, so I think this is it for this seminar. Do you guys have any questions? If you guys have any questions in the next few days, you can contact us. We will happily respond. And we wish you guys the best of luck for the test. And yeah, thank you so much for attending.
Thank you.
Thank you.
Thank you.
Thank you.
Bye. Good night.
I think you can stop recording now.
Yeah, 1 second. Okay.